Hello, and welcome to today's episode of Not Defined by Endo. I am so privileged today to be speaking to Dr. Olajuwon Alabi. For those of you who don't already know, I am a Nigerian and my heart has always desired to reach endometriosis sufferers in my home country. Dr. Juwon is a consultant gynaecologist and obstetrician and the founder and medical director of Southshore Women's and Children's Hospital in Lagos, Nigeria. Southshore is run both in Victoria Island and GRA Ikeja in Lagos. Dr. Juwon trained in Nigeria and also in Manchester and Leeds in the United Kingdom. He was trained in minimal access surgery and developed interest in this subspecialty, and there got involved in a lot of endometriosis cases. On his return to Nigeria, he realized the skills gap in laparoscopic surgery and decided in 2012 to start Southshore, which focuses predominantly on women's health. One of their specialties is the treatment of fibroids and endometriosis. He is an excision specialist, and today I'm excited to talk about what it is like treating endometriosis patients in Nigeria. We discuss the challenges and we receive golden advice from Dr. Juwon on dealing with this disease. Remember that I am not a healthcare professional, so whatever I share on this podcast is to inspire and empower you to take control of your health and your bodies. Please always speak to your healthcare professional before making any major changes to your diet or lifestyle. With that said, let's get right to it.
Hello.
Hello, good afternoon, sir.
Good afternoon. How are you?
I'm very well, thank you. First of all, I want to say thank you so much for agreeing to come on this show and speaking to me about endometriosis, especially as it relates to you being in Nigeria. So I appreciate it so much.
Thank you very much.
So I want to start with a quick introduction about yourself. Is it possible for you to tell me and the audience a bit about who you are and what you do? Yeah.
Okay, so my name is Olajuwon Alabi. I'm a consultant gynecologist and obstetrician. I'm the founder and medical director of Southshore Women's and Children's Hospital in Lagos, Nigeria. We run from Victoria Island, Lagos, and we also run in Ikeja, GRA. So about myself, I went to medical school in Nigeria, and then immediately after medical school, I traveled to the UK to have my postgraduate training. So I train around Manchester and Leeds. So now, during my training, I was lucky to be able to have gone through something called laparoscopic training. So laparoscopic training means minimal access surgery. That's you don't cut people, you use tiny cameras to look inside the womb. So I developed a lot of interest in that and I went through training for that. And then obviously came across a lot of endometriosis through that. So in 2010, after completing my training and working a while in the UK, I decided so I came to Nigeria for some visits. And then I realized that they don't have a lot of people doing what I do in the UK, which is keyhole surgery. So I felt, it's an opportunity. I mean, when I was going to the UK, I always felt I was going to come back. I didn't intend to stay. So I decided to come back. And then I worked in a few hospitals. And then in 2012, decided to start Southshore. So Southshore is dedicated to women's health, and one of our strong areas is treating fibroids and endometriosis. Now, I mean, Black people are well known to have fibroids, but I think there was a time a lot of people thought that endometriosis does not affect Black people, especially in Nigeria. But I can understand that because part of the infrastructural problem we have in Nigeria is that a lot of hospitals don't do laparoscopy. So because of that, they cannot diagnose endometriosis. So they think that they don't have a lot of patients. But that is changing. I think the concept of that is changing. So yeah, I work in Lagos and I treat a lot of people with endometriosis.
Amazing. Thank you very much for that. So I have probably discussed this a million times on my podcast, but I love that you said that one of the issues that maybe causes people not to be diagnosed as much is because there's not a lot of keyhole surgery being done, which is very vital because we know that that's one of the almost like the gold standard of diagnosis is doing a keyhole surgery. So I want to ask a question about symptoms of endometriosis. For people who might have endometriosis, what are the symptoms that indicate that this could be endometriosis, and then they should push for, maybe some kinds of intervention or some kind of diagnosis for endometriosis?
Okay, so the first thing is that there are lots of people that are asymptomatic. They don't know that they have endometriosis, okay? Maybe they just have a routine scan and then the doctors see that their pelvis doesn't look right. So there are people like that. But some other group will have symptoms. So there are common symptoms of endometriosis, but there are also symptoms that are not very common. So let's start. One of the major problems with endometriosis is that it's not diagnosed early, because if a young woman or a young girl start having periods and then they start saying my period is painful, a lot of people just assume that, well, it's true. A lot of women have painful period and that's it. So painful period is a symptom of endometriosis. And as the pain grows, so a lot of people focus on, oh, the pain is different because it starts from a few days before your period. Not everybody. I think everybody is different. Endometriosis just means pain. The pain can be before the period, it can be during the period, it can be after the period. It can be pain during ovulation, it can be pain when you go into the bathroom to wee. It can be pain, it can be bloody wee. It can be pain when you're having, when you're moving your bowel, or it can be bowel issues. You suddenly start having diarrhea or constipation around your period. And then endometriosis can be found in different parts of the body as well. Some people will start having breathlessness when it's around their period because they have endometriosis in their lungs. Some people will have it in their brain. It means that every time they are having periods, they have this severe headache and different. So now it takes us to the next level because endometriosis causes a lot of inflammation. So somebody might have it, and the first time they are presenting is that, oh, doctor, I'm struggling to get pregnant because it has damaged a few structures inside their tummy. And it might be that, so that is fertility. Now, there's another type of endometriosis that is peculiar. It seems to be common among Black people, which is they have a lot of fluid in their tummy, something called ascites. Now, when I was in England, it wasn't as common, but when I came back to Nigeria, I've seen a lot of people with that. They have this massive fluid in their tummy, and it's secondary to endometriosis as well. So it presents in different ways. And, I think, like you rightly said, yes, you can have the instrument to diagnose it, but looking at your case, even the thinking of it, you might be in a developed place where they have all the instruments or the equipment. But if the doctor is not aware or is not very conversant with endometriosis, then there will be delay in diagnosis. And there's been a lot of research like that shows that in endometriosis, there seems to be a constant delay in diagnosis. I hope I've answered that.
Yes, definitely. That's really helpful. I love that you said endometriosis is almost synonymous to pain because it's just pain, not just period pain, but pain, bowel movements, some people pain during bladder movements, just pain. So yes,
yeah,
I think
I forgot. I was going to remember one as well. Painful intercourse as well. You're married and you're having sex and it's all painful. I mean, I saw a couple I operated on a couple about a month ago, and she is 40, and we're just diagnosing endometriosis. They've been married for about 5 years. Wow. And the husband said that every time she wants to have a period or they want to have sex, she's a totally different person. And for the first time, after their surgery, she's had one period. And you can see that she said that it's totally different.
Wow.
So diagnosing is very important. Delay causes a lot of problems.
Okay. All right, thank you for that. So I will talk about how you, so I already know that you said you use laparoscopic surgery to diagnose, but I want to talk about your treatment plans and how you deal with your endometriosis patients. But before then, I wanted to ask about the myths that are surrounding endometriosis. So many of us, when we go to the doctor for the first time, they could say, go and get pregnant, like even before they diagnose endometriosis, they might say, try and get pregnant, the pain will go down. That's something even my grandma used to say to me, that, don't worry, in Yoruba, by the way, don't worry. Once you're done, once you get married and start giving birth, this will reduce or something like that. So that's one of the things they say. I understand why they would say that, but there are so many myths surrounding endometriosis. For example, another example is hysterectomy will cure you, things like that, or teenage girls or younger girls can't have it. So could you share with us some other myths that people are talking, like people say or people talk about, that we want to, make sure that apart from spreading awareness about endometriosis, we are also letting them know that this is misinformation out there and they should stop saying it?
Yeah, I think that, you've mentioned the main one. But let me go back a bit as well. So people can have period pain without having endometriosis, because sometime in people, if you've never had children before, your womb wants to pass out blood from your period, and it has to force it out. So that can be painful. But when the pain is intense, and some people, when they're in their period, they get admitted to hospitals and stuff like that. That's almost saying that go and look for something. You might have something totally different. So, like you rightly said as well, when you have endometriosis, even when you get pregnant, the pain will still be there and it will come back. So endometriosis pain do not go with childbirth. You need to understand that. So there's no point. There might be some sense in that, because fertility seems to reduce in endometriosis patients. So this, if you have endometriosis of the ovary, sometimes it reduces the number of follicles there because of the inflammation and stuff like that. So in somebody that doesn't have endometriosis, the age in which they lose, or when they say biological clock, the age that they reach biological clock is about 40, 41. With endometriosis, it tends to reduce even further. So I think it's important that somebody that have endometriosis understand that, so that they can make decisions. It doesn't necessarily mean that they have to have a child, but they can think about fertility preservation, maybe keeping their embryo eggs somewhere, so that in a few years, if they meet a guy or whatever, they can go back and say, okay, can I have my eggs back? Yeah. And stuff like that. So those are important things. Now, one of the major problems in Nigeria is that everybody is scared of surgery. So unlike where you are, that you can go to a gynecologist and say, oh, I want to have, I have this pain. And the gynecologist say, okay, yes, you need a laparoscopy. I'll put you on the waiting list. In Nigeria, the concept is slightly different. So you go to somewhere and you say you need surgery, and you go and tell your family at home. I'm sure you understand what will come out of that. Surgery, no. And then they can dissuade you from having surgery for a long time until the pains become severe or unbearable. And endometriosis is a progressive condition. It starts with mild, and then if it's not found or treated on time, it starts getting worse. So it's important that early diagnosis is important, and then you can be managed properly.
Yes.
Hysterectomy does not cure endometriosis. Even removing the ovary sometimes does not cure it. I think it's important. It reduces the pain from it, but so that's why an endometriosis specialist is very important. So to make decisions, you've got to find out where the endometriosis is. So let's say you've completed your family, you're going to resect wherever the endometriosis is to have cure. So it might be your womb, it might be your ovary, it might be the bowel, it might be the peritoneum. All of it might need to be resected. But one of the things I tell people is that so that we understand each other, endometriosis is a condition that you might have to live with, till you reach menopause. I think it's so what you're looking, sometimes when people go into hospital, what they want is cure.
Yes.
Now, it's important that somebody understand and put you through this and say, well, I might not be able to cure you with endometriosis, but I will be able to give you a good quality of life. That's what we need, a good quality of life so that you can live and then manage your condition so that you can complete your reproductive intentions.
Yes.
And then, live normally. So that's what I will say, really.
Okay. Amazing. So can we talk now about your treatment plans that you always offer,
Okay.
you do offer your patients?
Okay, so I will go back to diagnosis. All right. So because diagnosis is important in the treatment plan. So the first thing is that when you see a patient comes in with symptoms, so you have to have the sensitivity. Some people use questionnaires, endometriosis related questionnaires, so that they can pick things that, for example, how's your bowel? How's your urination? How's sex? So that you have pointers, and it has like points for you to pick people that have endometriosis. Now, so your diagnosis might have started from highly suspicious of endometriosis by just speaking with somebody. So that is where awareness is very important to the doctor. So you already know that, okay, this person might have endometriosis. So the second part of it is scanning them. So when you scan people, so there are three main types of endometriosis, well, maybe four main types of endometriosis, really. So you have the one called peritoneal endometriosis. That means it's just on the surface of the tummy. Inside the tummy, it just deposits on the tummy. Then you have ovarian endometrioma. That's a cyst on the ovary. So there's like a chocolate cyst on the ovary. Then you have something called deep infiltrating endometriosis. That means they have like chunks, like nodule connecting or burrowed inside your bowel or burrowed inside anywhere in your body. And then you have the one that sometimes people will not classify as endometriosis, but it is as well, which is called adenomyosis, which is endometriosis of the uterus, of the womb. So sometimes that is not, so you're focused on the others and you ignore the last one. And unfortunately, sometimes you might have 1, 2, 3, and 4. Sometimes you might have 1 and 4. So it's important that the doctor looking after you think about things entirely. Okay, so you scan. So sometimes endometriosis shows on scan and you can say for definite, this is endometriosis. When you have people like that, you do not necessarily have to do surgery. If, for example, if a young woman comes to me and say, I have this pain, and then I scan them and I see endometriosis, we can sit down and talk about options of treatment. So options of treatment might be just painkiller. Now, that is difficult because a lot of time when patient comes to you, they've exhausted painkillers. They've used paracetamol, diclofenac, non-steroid, they've used all that and it's not working. So it takes us back to definitive treatment, which can be hormonal or can be surgical, okay?
Yes.
So now in this part of the world, there's so many people that have had the wrong surgery, which is open surgery. And then that causes, by the time you're seeing them, the doctor that did the open surgery did not even know they have endometriosis. So it's caused a lot of adhesions and scar tissue inside them. So treatment is related to many things. So the things that are important in treatment are, how old is this person? One, do they want to have children? Are they trying to conceive now, or fertility is not an option for now? Are they having bowel issues, or are they having heavy periods and things? So you take their symptoms and make a decision. And also, how old is this person? Is this person a young girl? How many surgeries have they done before? Have they done like 5 surgeries before they're getting to you? I mean, what is their fertility? I mean, for example, you're coming in contact with a young woman who's had like 4 surgeries where they're coming from. Also, who did the surgery? Is it a endometriosis expert that did the surgery or nobody else before you're offering care, okay? So some people will just need hormonal treatments, the pill, the oral contraceptive pills. So what I tend to do sometimes is that I do something called tricycling. So I give them the pill and there's no break in between the pill. So it means that instead of having a period every month, they might have a period every 3 months, which reduces the intensity of the pain and also the frequency of it, especially in women that don't want surgery. Now, there is another group that they might have used the pill and it doesn't work for them. You might want to consider other things like the depot injection or something called Mirena coil. If the main problem they have is painful period, so you might want to bring Mirena coil into it because that reduces their period and also reduces the pain as well, especially even if they have adenomyosis as well. Now, you can have symptomatic relief by using a drug, which I'm sure that you might have heard about, called Lupron or Zoladex. Or in the UK, sometimes they use a drug called Prostab. So these are injections. So the basis of endometriosis is related to estrogen. It's almost like the estrogen gives them power. Mm-hmm. So if somebody has a lot of estrogen or you deprive them of estrogen, the endometriosis might become less active and then the pain reduces. So you can use that. Now, if you've tried all that or there's a need for surgery, then you might be talking about laparoscopic surgery. Sometimes the challenge with laparoscopic surgery is that, and this is why it's important that experts treat endometriosis. Now, I remember when I was training in England, what we tend to do is that you will do something called diagnostic laparoscopy. You will diagnose the endometriosis, and then you will talk to the patient and say, madam, you have endometriosis, come back in 6 weeks or 3 weeks of 3 months, we will put you on the list for surgery. So it means that they might have 2 surgeries for the same condition. So the concept of that is changing a bit, which means that the person that's doing the diagnosis should be talking to the patient about treatment at the same time. Mm. So you're using the diagnosis to treat. Now, that has its own issue as well. And that is why it's important to have diagnosed it properly before you're going to that stage. Because you need to know what extent the surgery is going to. Are you just removing endometriosis? Now, that takes us to another point, which is, now you would have read that there are different groups of people. There are people that burn endometriosis and people that excise endometriosis.
Yes.
Excision means that you're removing that area. A lot of people, or when you're not, and I can say that maybe when I was a lot younger, I was part of that group as well. They burn endometriosis out. But what happens is that you're just burning it on the surface. Mm. And the inner part of it is not being touched. So after burning it, a few months time, the woman start having symptoms again. So excision of endometriosis, excising all the area where endometriosis is the gold standard for treatment. Now, part of this consideration in treatment is the fertility of that patient as well. Like I said before, the more surgery or endometriosis is, endometriosis causes a reduction in your fertility. One, by causing a lot of inflammation, damaging the tubes, reducing the quality of eggs you have. So by the time you're about to get pregnant, you're struggling. Now, you're already struggling because of that, and then you come to a doctor to treat your endometriosis. If the doctor is not careful, it can cause further damage by, if it's aggressive, it might remove some of your follicles and then make you a bit more infertile. So it's almost like a fine balance between treating your symptoms and also making sure that you can have children.
Yeah.
And so those are the things that you consider. Sometimes you might need to do a joint surgery between yourself as a gynecologist and a bowel specialist as well, because if endometriosis affects your bowel, you might need to detach that part of your bowel so that you are removing the nodule of endometriosis. So you might need a bowel expert to join the endometriosis together, once you remove that part of the bowel, to join the bowel back. So really, endometriosis should be managed from the multidisciplinary point of view. It's not only one person. You should have a specialist nurse, a doctor, a gynecologist, a general surgeon, and somebody, a radiologist that is known or an expert in doing scans and MRI and stuff like that for endometriosis. I don't know whether I've answered your question, but
very
that's the way I take
well.
it.
You've definitely answered the question in a very complete manner. So I wanted to ask something regarding something you mentioned, which is in terms of the treatment plans. I love that you said that, and that's one of the things I've been trying to say as well. As much as excision surgery, when you do surgery, excision has to be, gold standard, not ablation, and it has to be done in a very interdisciplinary and holistic manner. But in terms of, if we talk about the hormonal treatment, one of the treatments you mentioned, which was Lupron, is one treatment that seems to be a bit controversial. So I speak to doctors about this. I try not to shy away from it because I want there to be like understanding, I will say, between, the endometriosis patients who are very well informed and also the doctors or the healthcare professionals who are skilled in the field. And Lupron is one, drug or hormonal treatment that many people say have very devastating long-term side effects. So for example, saying that they have like bone density loss or some really strong side effects. So I wanted us to talk about it just a little bit more to make sure that people are also aware. So while these are the different treatments, there are some things you should know about so that you go in with an informed in an informed manner and you make that decision knowing exactly what you're getting into.
Okay, so let me start from a story. So about the first surgery, actually, when I started Southshore, the first surgery I did is on a woman who has endometriosis. At that time, she was younger, she hasn't had a family yet. And we found out that she has severe endometriosis. So thank God we did the surgery. And then she got pregnant. And then she had a baby. Now, about a year or two into that, she came back and the symptoms have come back. And when I scanned her, the endometriosis have come back and she's in a lot of pain. So we had a chat. She's used every hormone that doesn't work. So we had a chat. She wasn't meant, I think she has a school. She has a private school. She's the headmistress. And at that time, she doesn't want to have another surgery. So I put her on Lupron or Zoladex, which is what they use here, Zoladex. Now, she was pain-free, but one of the things about Zoladex, like you rightly said, is bone mineral density. So you must not use Zoladex without add back HRT. So it means that, so the way I explain this is that you're taking 10 estrogen from somebody because it's causing severe pain, but you're giving them 1 or 2 back, and that 2 can go and cover their bone or where they need it.
Okay.
Now, I think it's about people making choices. Somebody might have had 3 or 4 surgery and they're not ready to have anything and nothing works for them. So everything have a reason for you to use it, but you have to use it safely. And the person that you're using it for need to understand why you're using it and also the side effects of it. I mean, I've used Zoladex before where the woman came and said, I had psychological problem with this. I was almost going insane. And then we had to take her off it and look for something else. There are other drugs as well. I mean, there's this new drug. What's the name of this new drug that is purely for endometriosis. I think we were struggling to get it in Nigeria, and it was quite expensive. I don't know why I've tried to get it. Sorry?
Is it Aurelisa?
Yes.
Okay. Yes.
Yeah, we were struggling. It's a very expensive drug, and we were struggling to get it. But those are things that can come on the table. Now, remember that in your country, which is England, I'm sorry to say that, you might be able to get that because people don't pay for health. Over here, if you tell somebody that, okay, Zoladex is 30,000, this drug is 400,000. Both of them might have the same kind of role. What do we do? I'm sure you understand that. So cost is a very important part of this. I mean, using any medication, whether it's paracetamol, whether it's the pill, you should have had an informed decision, a very informed discussion at the beginning, and then the person go on it. Now, the other thing is that if people use Zoladex for a few months, maybe 6 months, maybe 12 months, and then if you can incorporate bone mineral density study into that, so that if there's any issue, you can pick it up a lot earlier. But it's an alternative. It works for some people, it doesn't work for some people. It's not the all cure. It's just, for me, I use it if I cannot do surgery for different reasons, or I use it sometimes before surgery, so that it helps me reduce the inflammation that I will see by the time I'm going to do surgery. So it's not a cure drug, but it's a complementary drug. So, and you have to treat people totally differently as well. Some people, I mean, I have somebody on it, I think she's had 2 surgeries. Remember that by the time people come to us, sometimes they've gone through some processes. Most times it's an inadequate. They've gone through a process that is inadequate, but you're now in a position. One, they've spent a lot of money to do surgeries that has not helped them. You're in a position to either do another surgery or maybe give them time to recover from their financial positions. So the question is that while you're waiting, what do you do? So those are where Zoladex and Lupron and everything, but it's not like a drug that, oh, you have endometriosis, you have to go on it. It's a totally, you have to look at what is peculiar to this person that you're treating.
Yes. Wow. Fantastic answer. One of the things you mentioned, which is so very important, is the fact that cost of treatment, especially in a country like Nigeria, is a big barrier to, treatment or a challenge when it comes to endometriosis. You also mentioned earlier that things like people being afraid of surgery, or, there's that thing in Nigerians like, surgery, God forbid, we don't want surgery, something like that. Are there any other challenges that you think or are part of the issues or the problem? So that I think that if we talk about all these things, then we begin to talk about how to address each of these challenges. So are there any ones that you've thought of or of that?
Okay, so the first thing is the experience of the doctor as well. So I'm sure you are aware that in most part of the world, there are hospitals that are endometriosis center. Now, when I got to Nigeria, maybe one or maybe the doctors doing laparoscopy, maybe 2 or 3. Wow. But now it's a lot more because people are getting a bit more aware. Now, you also need to understand that the skill to treat endometriosis is not something you can develop in a year or 2. It has to be a skill. Either you've gone through a well-organized training, or you have been doing this for a long time, so you've developed yourself into doing it. Now, if a doctor started doing this procedure and started in a year, the kind of treatment or the kind of skill they'll be able to offer this lady is totally different from a very experienced person. One of the challenges in Nigeria as well is that sometimes doctors find it difficult to refer patients. So I'm a private doctor, Mr. X is a private doctor, this woman needs this procedure. It might be that rather than I refer to this doctor that has the skill, I might want to do what I can do, which is not in the best interest of that patient. So that's a challenge here as well.
Yeah.
You know, the skill level of the people doing, you might say that, and that's why it's difficult. So you might get a patient who said, oh, I've done 3 laparoscopy surgery in XYZ, but you as a doctor, you know that, you know those people, and you know that they do not have the skill to do extensive surgery. So what do you do with that? You want to either go back and do the surgery or tell them, you know, these people have paid a lot of money to do their here. They might not even have the finances to do the procedure at your place anymore. So yeah, so those are the kind of challenges we get here.
Wow.
Now, laparoscopic equipment are quite expensive here as well. And if you go to a lot of the teaching hospitals, which are meant to be center of excellence and stuff like that, they don't even do laparoscopic surgery. Not to the extent of, so all the patients that go there, where do they do their surgeries? So those are the challenges peculiar to Nigeria, really.
Wow. So for those that don't do laparoscopic surgeries, do they just do laparotomies? Like, do they just do open surgeries, or they just don't do surgery? What is the answer?
It's difficult for me to answer that because I don't know.
Wow.
But those are the challenges, really.
Okay. Thank you for that. So now that leads, I guess that naturally leads to the next question. So we know that, you know, there's not a lot of skilled endometriosis experts in Nigeria, and that's a problem, because even in other parts of the world like the UK, where they have, you know, quite a number of skilled surgeons, they still say this is not enough. Like, I think in America they were saying we have like 100 excision specialists in the whole country, something like that. I'm not sure if I got that number right, but it was ridiculously small. So that's definitely an issue. But would you say that there are at least some, you know, a group or a number of skilled surgeons that, or skilled experts that endometriosis patients in Nigeria could go to, apart from you? So we know that you're an excision specialist, thank God. And there are others as well, probably in Nigeria. But I've noticed that there's this Facebook huge group on endometriosis called Nancy's Nook. I don't know if you've heard of that group, but it's called Nancy's Nook. It's it was created by a lady, an endometriosis patient, and she's like, I think she's a retired nurse. Her name is Nancy Peterson, and she's been fighting for endometriosis. So she has this Facebook educational group where people join, and there's a lot of information. And on there, she has a list of excision specialists so that people know who to go to. So, for example, what you said is so key, that some doctors would just take the case and do it, even if they're not that skilled, which is quite dangerous. But I guess people do that. So that list is supposed to tell at least people based on your area, you know, or where you can go to, that these are doctors that have been kind of patient verified, that this, you know, doctor was so good, he did excision surgery, he listened to me, blah blah blah. And then I looked for that on that list for Nigeria, and there's hardly anyone on there. I don't remember seeing you on there, but I think you would know if you were on the list, because she would reach out to you. So that's one of the things that I would love to change. Like, even I can reach out to Nancy Peterson and say, you know, Dr. Juwon Alabi is a doctor in Nigeria. Like, what's the process of getting his name on the list? Something like that. So my question to you now is, are there others that people listening to this podcast right now can, you know, probably go to apart from you? Since you can't do it for every Nigerian that has endometriosis.
Yeah. So one of the things, so like I said, when I came to Nigeria, there were not a lot of people doing laparoscopy. So we set up a group called the Association of Gynaecological Endoscopies of Nigeria, which is a group of people doing keyhole surgery. So I'm the vice president of that society, the National Society. And one of the things that we're hoping to be able to do is keep developing skills. Now, the difficulty with Nigeria is that you cannot verify skill because they have not gone through a process of training. A lot of people go to India to train for maybe a month or 3 months, and so I can't verify the skill. But what I know is that there are some centers in Nigeria where people from England, specialists from England, come to operate in those centers. I
Okay.
can give you name for that. So
Okay,
for
that would be
example,
great.
there's a place in Nigeria called Nordica Fertility Center. They have people, I know a couple of people from the UK that come there.
Okay.
There's a place in Abuja called Nisa Premier Hospital.
Okay.
So I know that they come from the UK as well. Now, locally, I don't really know the extent of the skill of the local people in relation to endometriosis.
Okay. I think that's a
Yeah.
fantastic, though. Nordica and Nisa. So it's good for people to at least know about them and maybe do their own research and figure
Yes,
out.
absolutely.
Yeah, that's really
Yeah.
helpful. Thank you so much for that.
No problem.
So let's find. I had two more questions, and then we're done today. First of all,
Okay.
you mentioned, and this is something I personally have experienced as well, ascites, which is a manifestation of endometriosis where there's lots of
Yeah.
fluids, filling up in the tummy and all of that. So for some strange reason, it seems to be very common in Black, especially nulliparous women. I don't know why.
Yes, absolutely.
I don't know why, but do you have any? I think you mentioned that you've seen quite a number of people there. So, what is the treatment process like for people that have ascites, and how does this affect things like fertility as well?
Yeah. I mean, interestingly, so when I was training in England in 2000, I think it was 2006, maybe 2007, I came across a case report and I wrote it up. And it's on the, there's a case report that I wrote about ascites. So it's one of those things that a lot of doctors don't see in the UK. But when I came back to Nigeria, I started seeing a lot of it. So you see these people that over the years, they've been going to hospital for drainage of bloody fluid inside their tummy. Now, what happened is that people drain it, but because you cannot do laparoscopy, they don't confirm the diagnosis. So the ones that what we've done is that we have used laparoscopy to drain their fluid. Sometimes you drain as much as 10 liters, 15 liters. Now, if you don't do anything, they will come back. So what we tend to do is we put them on, going back to the Zoladex. So I put them on Zoladex for a period of time. Now, you can use the laparoscopy to assess their skill, their fertility as well. I mean, I know that there's somebody that we treat. Now, one of the challenges in Nigeria is follow-up as well. When you treat people, sometimes they don't come back. But I remember there's a lady who we treated about 3 years ago and got pregnant because she has severe endometriosis. Immediately we drain it, we put her on Zola, we just send her for IVF. And then she got pregnant and she's had her baby now. I think she's on if I remember, I think she's on the pill or the injection now. She's on one of those hormonal treatments.
Okay.
So I think, like I said before, with endometriosis, you have to think about fertility very early. Now, if I drain her fluid and leave her, the pill and all other are not very good at keeping ascites quiet. People still come out with ascites with it. There's a new drug called letrozole.
Okay.
That people feel that reduces the fluid production with endometriosis. I've spoken to a couple of colleagues that works in teaching hospitals where their patient cannot afford Zoladex and things and Lupron and stuff. So they use that and they said that it works for people.
Okay.
So, but I don't have a lot of experience with that. Now, so by the time you're draining the fluid, you're assessing their fertility as well. You're looking at whether the endometriosis you're looking at the stage of endometriosis they have. You're looking at whether it has damaged their tubes. You're looking at something called the ovarian reserve, which is AMH. You want to see what level so that you use that. And then, I mean, if a young woman that has no partner, you cannot be telling them about fertility and go and have children. So you want to manage them and in a situation like that, I use a lot of Zoladex and it helps.
Okay.
Now, in somebody that is married and is thinking about fertility, you probably want to drain the fluid and also maybe put them on Zoladex and then get them into a fertility cycle, treatment cycle, like IVF and things like that. So it depends on different people. Now, moving forward, if they have their children and their ascites is coming back, then you need to find something that's going to keep their ovary quiet, because ascites in endometriosis is almost like an inflammatory response. So it's totally, so an inflammatory response can be adhesions, scar tissue, but it can also be fluid. Now, what we haven't been able to find out is that why does it happen in this group of people like that? Nobody knows that.
Maybe someday research will tell us.
Maybe someday, maybe someday.
As we continue.
And I'm just thinking now that why can't we research that? Why can't we look at why do this group of people have fluid and stuff like that? Yeah.
Maybe that's my PhD topic.
maybe.
Who knows?
Maybe, who knows? Yeah.
All right. Thank you so much for that very succinct answer. So final question is, we talked about endometriosis obviously being a progressive condition. It's one that requires a multidisciplinary approach. And it's also one that kind of requires a holistic approach. So one of the things that I, in my personal experience, did that helped me even before I started, actual treatment, was doing things like really looking into my diet and what I'm eating, my nutrition, my stress levels. I did some sessions of pelvic therapy as well, because apparently with all the pain you're going through for so many years, your muscles become really tense and all of that, drama when it comes to endo. So I try to do all of that holistic approach where I'm not just looking at, the medical aspect of it. I'm also looking at other nutritional lifestyle approaches. So would you say that has is something that you also talk about to your patients? And do you find that maybe it helps a bit when there's almost like a monitoring of what their triggers are, what their symptoms are, and using that as a way to manage their lives, their quality of life as well?
Yeah. I think one of the things I've realized is that although the research doesn't support it, is that fibroid and endometriosis, they are food that triggers the development of fibroid and hereby endometriosis as well. Now, one of the challenges we have here as well is that a lot of our patients have both conditions. So they have fibroid and they have endometriosis. And I think it's most likely that there's a common pathway somewhere between them. But now, estrogen is important in both groups, fibroid groups, endometriosis groups. And there's been a lot of studies looking at estrogenized food. So food that are, and there are lots of them on the internet that shows these are food that when you eat, it has a lot of estrogen in it. I mean, so my own perception is that I think we eat a lot of starchy food here in Nigeria. We eat a lot of starchy food. We eat a lot of things like yam and stuff like that.
Yeah.
Now, if you think about it as well, I don't know, and this is just hypothesis, it's not proven. Remember that some part of Nigeria is well known for having twins because of the kind of food they eat in that group. Maybe, So I'm thinking that if we can look at our food and our diets and maybe tone all that down or remove it. I've seen a lot of people come to me and say, oh, doctor, when I started looking at my diet, my fibroid doesn't seem, I don't feel as much pressure as I used to feel anymore. So it seems as if, I'm totally agree that the diet contributes somehow. My own theory as well is that, because I always think about why do we have so much extensive fibroid in this part of the world? Now, the fact that we might have a gene that makes us prone to it, but there must be an environmental factor.
Exactly.
That pushes that as well. So I think that diet is a very important component of all this. And it's something that we need to start talking about or addressing as well. I think so.
All right. Thank you so much. So is there anything else that you'd like to say to any Nigerian listening, people who, I know that there are lots of people that feel like it's a thing of shame. And this is what I'm trying to say. Like it's not your fault that you have this. So no shame here, no judgment here. But is there anything else you'd like to say to anyone who probably has endometriosis as a diagnosis already, or has symptoms that make them think they might have it, what would you like to say to them?
Well, I think the first thing is that endometriosis is a very is one of those medical conditions that is an enigma. If you have it, you have to find a way to deal with it. Now, what I also need to tell people is that when you go to a doctor, you have to understand that the doctor may not be able to cure you. I think that's very important, so that, because a lot of people go through all this process and get extremely disappointed. I know it's disappointing, but that discussion must be from the beginning, that I might not be able to cure you. I might be able to give you a better quality of life, though, because this might be a life. It might just be that we need to manage it until you complete your family, until X, until then. And management might be different at different stages of your life. Now, it's also important that when you want to have treatment, if you're somebody that wants to get pregnant, you should talk about that with your doctor. It's very important that you do that. And it's very important that you meet a doctor that is very knowledgeable at what they do. That is very important. And if you get a first opinion, I think you should also try to get a second opinion as well. Now, the challenge for me with second opinion in Nigeria is that you might come to a doctor who does a lot of laparoscopic excision. But the question is that when you leave that doctor and you want to go for a second opinion, where do you go? That's the challenge here. Because it's not like for like. If you go to somebody who doesn't do laparoscopy, it's not, that's a waste of time, because they're going to tell you completely opposite of what I told you. So my take on it is that please join a support group, speak with people that have gone through this journey before, understand your condition properly, understand how it affects you, plan your life as well. You can, you don't have to go and get pregnant immediately, but think about it. Where am I? Because it will be a shame for you to say that, to see a doctor, you want to get pregnant, you want to have children of your own, and then you see your doctor, you were diagnosed with endometriosis at 29, and at 36, a doctor is telling you that unfortunately you don't have good quality eggs again. Meanwhile, at 29, 30, 31, you could have saved your eggs and stuff. So those are discussions that you need to be having with your doctors. That's what I mean.
Wow, amazing. Thank you so much, Dr. Alabi. This has been absolutely fantastic. Thank you.
Thank you very much.
In all parts of the world, approximately 1 in 10 women has endometriosis, and the average years it takes for diagnosis is 7 to 10 years. Each country, based on their healthcare system, their culture, their advancements, and so many more factors, could have longer diagnosis and treatment times. It has been great to understand how the culture, the system, and even the skills of the physicians in Nigeria play a big role in treatment and diagnosis. As we continue to fight to raise awareness about endometriosis, we will continue to shine light on not only the Western world, but all parts of the world. If you enjoyed this episode, I would love to know. Join me on Instagram and Facebook. You can also join our community on Health Unlocked and ask any questions or share your stories. Don't forget to share, rate, and subscribe to this podcast. If you also have any questions to ask or topics you would like me to discuss, feel free to shoot me an email on info@notdefinedbyendo.com. I love to hear from you all. Till next time, remember, you are not defined by endo.